Hello, I'm Dr. Manish Thapar, and on behalf of CME Outfitters, I'd like to welcome you to today's educational activity, addressing the unmet needs of patients with acute hepatic porphyria. This is supported by an educational grant from Alnylam Pharmaceuticals. This CME activity is brought to you by CME Outfitters, which is jointly accredited provider of continuing education for clinicians worldwide. I also want to encourage you all to join us today on a live Twitter conversation at CME Outfitters. We'll be monitoring the Twitter feed and responding to your tweets as they come in. I'm Manish Thapar. I'm an associate professor of medicine in the Division of Gastroenterology and Hepatology at Sidney Kimmel Medical Center at Thomas Jefferson University in Philadelphia. And it gives me great pleasure to also introduce my esteemed colleague, Dr. Brendan McGuire.
Thanks, Manish. Hi, I'm Brendan McGuire. I'm Medical Director of Liver Transplantation at the University of Alabama at Birmingham. I trained under Joseph R. Bloomer, who passed away last year, and have been managing patients with porphyria for over 28 years. It's been fun to see genetics assist with the diagnosis and additional treatments become available. Our first learning objective today is to relate disease etiology and pathophysiology to clinical manifestations of acute hepatic porphyrias, or AHP. We'd like to start with a polling question. We are all aware that AHP is a rare disease. So we have two questions here just to gauge our audience and the familiarity with porphyrias. First question, how many patients with acute hepatic porphyria are you caring for in your practice? None, 1, 2 to 5, or more than 5? Please answer at this time. Nice little music while you select your answers. But thank you for doing this. Very helpful to us.
I think we're moving on to the next question, and we'll probably show the results later, it looks like.
I think we are too. Sorry about that, guys. For our second polling question, which of the following types of acute hepatic porphyrias is most common? Acute intermittent porphyria, or AIP, aminolevulinic acid dehydratase deficiency porphyria, sorry about that, ALAD deficiency porphyria, hereditary coproporphyria, or HCP, variegate porphyria, or VP, or I'm not sure. Okay, there we see our answers. And most people did get it correct. Acute intermittent porphyria. Well, very good. Well, thank you. So next, we would like to show a 2-minute whiteboard animation geared towards patients, or if you like, it's also available for you at CME Outfitters website. Okay, please roll the patient video.
Acute hepatic porphyria, or AHP, is a collection of rare genetic diseases, often associated with debilitating symptoms and potentially life-threatening attacks. There are 4 types of AHP: acute intermittent porphyria, or AIP, comprising about 80% of all cases; variegate porphyria, or VP; hereditary coproporphyria, or HCP; ALAD deficiency porphyria, or ADP. For most types of AHP, the disease can be passed from parents to children if one parent carries the defective gene. Women suffer symptoms more than men, although most people have only one attack or no symptoms at all. For symptomatic patients, ongoing pain and symptoms that mimic those of other diseases can interfere with the ability to live a normal life. Unpredictable severe attacks of abdominal pain are common. These symptoms could lead to physical and emotional suffering and exhaustion. AHP occurs when there's a problem with the heme protein in the liver. Heme proteins are valuable for the production of hemoglobin in the bone marrow and for breaking down medications and other substances in the liver. When heme is not properly produced, toxins called PBG and ALA collect in the liver and circulate throughout the body. ALA and PBG are associated with painful attacks and other disease symptoms of AHP. Simple tests can be performed by your doctor to confirm AHP, including genetic testing. The earlier the diagnosis, the better. Recognize and avoid things that may trigger an attack. Certain medications, alcohol, smoking, or fasting or low-carb diets. Be sure to talk to your clinician about new and emerging medications that may help. It may be a difficult journey, but improvement and reduced attacks are possible. For a list of resources and questions to ask your clinician about AHP, visit www.cmeoutfitters.com/liver-hub.
Unfortunately, since this is a rare disease, many of our patients feel they're alone and isolated. I encourage all my patients to jump online to either the American Porphyria Foundation or the United Porphyrias Association. Both of these patient resources are valuable, and our patients truly do enjoy it. Next, we will transition to the few slides really done the overview really of porphyrias. Porphyria is an ancient Greek word, porphyra, meaning purple. The name refers to the color of urine that many occur during an attack with these conditions. There are 8 enzymes necessary for the production of heme. Porphyria is a group of genetic diseases associated with a defect in one of these enzymes. Clinically, symptoms of porphyria is the accumulation of these metabolic intermediates. Porphyrias are classified by clinical symptoms as either acute hepatic porphyria, or AHP, or photocutaneous porphyria. These symptoms associated with AHP are related to elevated levels of delta aminolevulinic acid, or ALA, which is neurotoxic, or to elevated urinary levels of porphobilinogen, which when degraded in the urine causes the urine to turn purple. The symptoms of photocutaneous porphyrias are related to elevated levels of porphyria, or porphyrins. Porphyrin molecules are tetrapyrrole molecules that are very similar to chlorophyll molecules in plants. We know that plants use chlorophyll to take sunlight and convert it to energy. Unfortunately, humans do not have the ability to take sunlight or convert it to energy. Thus, the photocutaneous porphyrias are related to elevated porphyrin levels. Almost all cells in the body contain heme proteins. 80% of all heme proteins are used to make hemoglobin in the bone marrow. The majority of the other heme proteins are produced in the liver and are important for degrading drugs, toxins, and free radicals via the cytochrome P450 enzymes. The enzymatic process of producing heme is called porphyrin synthesis. This next slide will show us the 8 steps necessary to essentially make heme. If you look, starting with the glycine plus succinyl-CoA, this is the actual pathway. To the right of that then is the enzyme needed for it. And then to the far right of that is if there's a defect in one of the enzymes, then it will be associated with one of these types of porphyrias. If you notice, there are yellow boxes. Those are the cutaneous porphyrias. And then you have the red boxes. Those are the acute hepatic porphyrias. And essentially, if you look at the very top where glycine plus succinyl-CoA form, the next step is delta aminolevulinic acid, or ALA. And then the next step is porphobilinogen, or PBG. To move to the next step, which is the hydroxymethylbilane, it takes 4 porphobilinogen molecules to make up the hydroxymethylbilane. It is really the hydroxymethylbilane and everything below that that are really the porphyrins, and that's why they're essentially in the white box. This is important to note because if you're considering someone for porphyria, the most likely reflex is just to order porphyrins, but porphyrins will only contain stuff that are located in the white box. You will also have to get the precursors such as ALA and PBG that are above. So make sure you order porphyrins plus ALA and PBG if you're considering someone with porphyria. As you notice, the last step here in the pathway is the addition of iron to protoporphyrin via the enzyme ferroketolase to form heme. Consumption of heme by drugs, toxins, or free radicals will provide a feedback loop to stimulate the activation of ALA synthase. If there's a defect in one of these enzymes, there's an excess of precursors that essentially limits the amount of heme produced. In addition, the acute hepatic porphyrias in the red boxes tend to be associated with elevated levels of ALA, which is toxic to nerves and lead to damage to the central and peripheral nervous systems. Elevation in serum porphyrins is associated with photocutaneous porphyrias and are located in the heme pathway. The exception is X-linked porphyria, which is an induced enzyme defect that increases production of the heme pathway. Finally, hereditary coproporphyria, or HCP, and varigate porphyria, or VP, which occurs late in the heme pathway, is associated with both photocutaneous and acute hepatic porphyrias, since they're associated with both elevated ALA and porphyrins. Thus, we will focus the rest of the webinar on really the acute hepatic porphyrias, or the AHPs. These are very rare diseases, and most of this data will focus actually on AIP, since it makes up over 80% of the hepatic porphyrias. For AIP, or acute intermittent porphyria, it has a variable penetrance. Genomic-based estimates that 1 out of 1,785 patients, but less than 1% of these patients will exhibit disease activity. Acute exacerbations occur in genetically predisposed patients, usually a combination of both environmental and hormonal precipitating factors. Thus, it usually occurs in females more often than men. The majority of patients develop symptoms following puberty, specifically during the 3rd and 4th decades of life, and can occur in all races and ethnic groups. Symptomatic patients experience independent attacks that can often be triggered by something specifically, and we'll go through those precipitating factors. Here is a list then of the precipitating factors for the acute hepatic porphyrias. These are all events that essentially deplete heme in the liver, thus inducing ALAS transcription or function, such as drugs that stimulate the cytochrome P450 enzymes, crashing diets, cigarette smoking, excessive alcohol use, infections, surgeries, or even psychological stress. The symptoms of acute hepatic porphyrias are related to elevated serum levels of PBG, which are being excreted in the urine, and when left under fluorescent lighting for a few hours will give it a purple or reddish color. Or due to nerve damage from elevated levels of serum ALA. The nerve damage can precipitate acute attacks with painful crisis and autonomic nervous system disease, such as diffuse abdominal pain, hypertension, tachycardia, orthostatic hypotension, and even bladder dysfunction. It can involve the peripheral sensory or motor symptoms with chronic pain, paresthesias, or motor weakness. The central nervous system can also be involved with depression, anxiety, and or seizures. Duration of symptoms are variable and can last between days to months, especially if patients inappropriately are undertreated. Therefore, clinicians must have a high index of suspicion of disease, as patients can present with symptoms that can be attributed to an alternative disease process. If a patient with HCP or VP, they may present with skin lesions on sun-exposed areas. To help try to bring all these things together, we thought it'd be helpful to have a case to start with, and then we'll have another case later today too. So this is a case of an unfortunate patient with acute intermittent porphyria. This is Mag. She's a 24-year-old female who complained of severe crampy upper abdominal pain for 3 days and 2 days of lower back pain. She reduced her oral intake because of nausea and had non-bloody, non-bilious emesis for 4 days. Her last bowel movement was also 4 days ago. She denied any upper respiratory symptoms, no rash, fevers, chills, no trauma, no travel history, weight loss, alcohol use, no drug use, or not sexually active. Unfortunately, she had 4 previous hospitalizations over the past 2 years for similar symptoms of abdominal pain, nausea, and vomiting. During these episodes, she was evaluated with multiple CT scans, MRIs of the abdomen, upper endoscopies, ERCPs, but no cause was identified. During these hospitalizations, she required IV fluids for nausea and vomiting. Her pain was controlled with hydromorphone and gabapentin until she improved sufficiently for discharge. She says she hated going to the hospital because healthcare workers had accused her of being a drug seeker. A review of her symptoms noted bilateral hand weakness for 2 months. She also complained of dark-colored urine and was concerned about a urinary tract infection. Her past medical history included hypertension for 3 years and a laparoscopic cholecystectomy 2 years ago during one of her previous hospitalizations for acalculous chronic cholecystitis. Unfortunately, she had 2 subsequent hospitalizations after having her gallbladder removed. Her only medication was amlodipine for hypertension. She works as a pharmacist, but had a difficult time working because of recurrent hospitalizations. She lives with her parents. She's single, and as said earlier, she's not sexually active. In terms of her physical exam, it's as follows: blood pressure 140/90, heart rate 110, afebrile, BMI is 27, moderate distress, moving around because she says she just can't get comfortable in bed. Her heart exam is notable for tachycardia. Lungs are clear. Abdomen is bowel sounds are positive, diffusely tender to light palpation, but worse in the upper quadrants. No rebound or guarding or suggestion of peritoneal signs. Extremities are normal, but neurological exam is positive for obvious bilateral weakness in the extension of her wrist and fingers and decreased brachioradialis reflexes bilaterally. Laboratory data is notable for hyponatremia, hyperglycemia, hypomagnesemia, and normal serum lipase levels. No evidence suggests celiac sprue. She has normal liver tests, thyroid studies, iron studies, CBC, and platelets are also all normal. Pregnancy test is negative. During this hospitalization, she had a CT scan. CT scan notes abdomen, pelvis with IV and oral contrast, normal liver, mild dilated bile ducts consistent with the previous cholecystectomy, no biliary stones, pancreas, spleen, kidneys were all normal, small bowel, colon were normal, scattered stool throughout the colon, no adenopathy, normal arterial and venous vessels. She also had a urinalysis. With her urinalysis, the urinary culture was actually normal. So now we have someone now without a diagnosis for abdominal pain, with bilateral hand weakness. And essentially, we've had very similar patients, I'm sure, Manish, with patients who have presented like this. Unfortunately, like many other patients, they're around for a long time. They've had these diagnoses, or they've had no diagnosis, but multiple symptoms. How many patients have you had like this in the past?
Well, I think I want to thank you for presenting, the patient, which is an unfortunate but rather common presentation of patients and their diagnostic journey. There was a study out that said the average delay in diagnosis was up to 10, 15 years before it was diagnosed. So I think raising the awareness and then encouraging people to think about it is critical. If you don't mind, I do have some questions that came in through the audience, and we can just take them as we are. I think the first question was, how do people describe the pain associated with AHP? Stabbing, sharp, dull, diffuse, unbearable. That was one of the questions that came in.
Yeah. I've talked with Dr. Bonkowski about this. He worked with him in the past. It's very interesting. Some people say it's lower abdominal. I've had people say upper. I think I can't tell one way or the other. I think I've seen both. I really have. So I have a hard time trying to say. And unfortunately, what usually happens, if it's more upper abdominal pain, they get their gallbladder out. If it's lower abdominal pain, they tend to get their, uterus out, or appendix out. We've all seen that too. So I don't have a good sense that I could say, boy, this type of pain is really specific for AHP. I don't know if you have a better answer on that. I don't know if I answered your question or not.
No, I think you're right, and this is one of the audience. This was one of the audience questions. I don't have a better answer. A lot of times, patients' pain is, they describe it in different ways. It could be autonomic in origin too, right? And the presentation of pain changes over time, especially when you have them on treatment. The key is to listen to them and then see what the cause is, and then and kind of go from there. Another key point that I would probably point out, even in a patient who has a well-established diagnosis of porphyria, these patients are still at risk for having other causes of acute abdomen. Just because they're diagnosed, they're on Heme, doesn't mean they can't get peptic ulcer disease. So, you have to work them up just as you would any other patient who does not have porphyria.
Yeah, no, that's a great comment. No, I agree with you 100%. Right. A lot of times we just get focused on a diagnosis and we sometimes don't deviate from it. We have to every time.
Right. Let's take another audience question, because I think there's several important questions which are related to the clinical presentation. I guess the next one is, the patient had severe abdominal pain, but no mental status changes. Do most people with pain-related symptoms also have some level of mental deficit?
I usually don't see it. The only situation I guess I would throw out, I've had, you can't talk about people can present encephalopathic, right? What it's from, you don't know. The only issue is, you see people with seizures present sometimes. That's their initial presentation too. They'll be out of it. But that's really it. I don't really associate altered mental status as part of my differential when I think of someone presenting with acute hepatic porphyrias.
I totally agree, and I would probably add to what you said. Seizures is, like you mentioned, is one of them, right? But if they have hyponatremia, really severe hyponatremia, they may be presenting confused. But severe pain itself is enough to throw you off, and people can describe that as, I don't know, they describe it as fogginess and not feeling well. It's just the pain, right? But there are other things like we mentioned that can cause mental deficit. Should we go for another question, Brendan? Or
Yeah, let's go. Yeah, this is good.
This is good. Okay. I think the next one is, this should be an easy one. Is it possible for an individual to have both AHP and photocutaneous porphyria?
Yes, and that would go with the VP or the coproporphyria. Correct. Yes.
Right. You could certainly have both, they have both cutaneous and acute symptoms. That's what you're referring to. Or although if your question is a dual porphyria, which has been rarely described, that'll be very, very rare in the world. I have not seen a patient with dual porphyria. So technically it is possible, but I think you're referring to both cutaneous and neurovisceral symptoms. That's what you're describing too. This one, the next one is approximately what percentage of individuals with HCP are women? That's the next question.
Yeah. What was it in the study, the Envision trial? I thought, almost all women. I think it's like 95% women. That's my estimate. What's your
For
guess?
HCP, yes, you're right. So
yeah.
No, I want to thank you again for the presenting and the overview. Well, we can move on. I think we're okay with questions for now. So next up is our next objective, which is to apply diagnostic resources to identify and confirm a diagnosis of AHP. This is a patient, her name is Grace. She is young, 27 years old. She presented to the ED in moderate distress. She's had generalized abdominal pain for the past 4 or 5 days in association with nausea and vomiting. She had been trying to lose weight and started participating in a program. When she thought she developed UTI-like symptoms, she saw her PCP, who sent off a UA, and then put her on an antibiotic. She was started on trimethoprim sulfamethoxazole 5 days prior to her presentation. The only meds that she was taking was the antibiotic and an oral contraceptive, for which she has been on for the past 10 years, denied any associated diarrhea, melena, or blood, no respiratory symptoms, no shortness of breath, and was not really taking any other over-the-counter medications. On exam, Grace was mildly delirious. She was mildly confused, kind of like with the question you had. Slightly tachycardic, hypertensive, with the blood pressure of 146/96, so she was clearly uncomfortable. Her respiratory rate was 20 with a low-grade temp. Abdominal exam was mildly tender on deep palpation, mostly in the periumbilical area. No organomegaly. She did have reduced bowel sounds. Pelvic exam was unremarkable. There was no visible lesions, and her stool was obviously heme negative. This brings us on to our next question. So you suspect that Grace may have acute hepatic porphyria. The question is, which test would you recommend at this point? So we have some time to respond. Let's think about it and go for it. Yay. Yes, the majority of people did get the right answer, which is spot urine for PBG. So that's important to remember that, the spot urine for PBG, which shows increased porphobilinogen, is the first line test to diagnose acute hepatic porphyria. Now, it's important to just throw in a creatinine at the same time, just in case you have a sample which is overly dilute. 24-hour collection is really not needed in the acute setting. Now, this is a recent change in the past 4 or 5 years. So no 24-hour urine collection needed, just a spot urine along with the creatinine is what's needed. Now, urine specimen is ideally obtained when the patient is symptomatic. And it's important to remember that the urinary porphobilinogen or PBG levels are substantially elevated at or near the time of an attack. And then you may want to consider saving a sample for later second-line tests. So as Dr. McGuire mentioned earlier, we're talking about PBG. We're not mentioning porphyrins here. It's PBG that you really need to be checking. Normally, you have less than 2 milligram per liter of porphobilinogen in the urine. Anything more than 6 is usually indicative of the presence of disease, so 3 times the upper limit of normal. In an acute attack, the levels are usually 10, 20, 100 times upper limit of normal. And if you're suspecting acute hepatic porphyria, and you notice elevated PBG levels at least 3 to 5 times, then you should consider initiating management. And we'll talk more about management in the later part of this talk. If PBG levels are normal, and this is where, you should consider sending a urine for ALA and total porphyrins if your suspicion is high at that point. Second-line testing to confirm the diagnosis it relies on the measurement of ALA and porphyrins, and you also assess total plasma and fecal porphyrin levels. This helps us differentiate between the different types of acute hepatic porphyria. The most common one, AIP, is PBG is usually sufficient. And as a matter of fact, for most of the acute hepatic porphyrias, including BP and HCP, especially during an acute attack. DNA testing is recommended when you want to know what the family-specific mutations are. And also in testing asymptomatic family members with AIP. And the reason why this is important is because, as Dr. McGuire had mentioned in his slides, that the penetrance of the disease is very low. So you may have a genetic mutation, but that does not mean you have clinically manifest disease. So that should not be your first line go-to test. Patients may have mild anemia, usually normocytic, normochromic. Acute attacks, they may present with hyponatremia and hypomagnesemia. Impaired glucose tolerance may develop. Liver enzymes are normal, although during an acute attack, they are elevated, as we'll see later on in this presentation. Cholesterol and LDL are often increased, and so are the serum binding proteins, if you were to check them. Now, a big question that often arises is, why is AIP commonly misdiagnosed? As we saw, the symptoms are nonspecific and may mimic those of many more common disorders. Patients certainly have a very variable presentation, and family history is often unrevealing. And two of the most important things that we see in our clinical practice is why the diagnosis is not confirmed biochemically, and then they have elevated porphyrins, which are not that, which could be a secondary phenomenon with underlying diseases, and they're given a diagnosis of acute hepatic porphyria, or the second most important reason is an inappropriate diagnostic test is ordered, or there's a testing error. That's why patients are commonly misdiagnosed. So let's go back to our case, Dr. McGuire. I'll let you take it off from here. I think this was your patient.
Correct. So this is the first case we said with Maggie, and essentially the results of her delta aminolevulinic acid, or ALA, was 6 times the upper limits of normal, and her porphobilinogen, or PBG, was 23 times the upper limits of normal, confirming a diagnosis of acute hepatic porphyria. The genetic testing also confirmed the diagnosis of AIP. It was a missense mutation in PBG deaminase gene. Unfortunately, though, it took 5 hospitalizations to make the diagnosis. Our hope really is with this webinar that we can actually prevent this from happening in the future by educating everyone out here today. I have a few other questions, Manish, that I have, and I think it's worth mentioning. Someone asked a good question. Should patient education be a greater priority since the busy clinician has so many other things to do, and it's a difficult diagnosis on the radar.
Oh, I'm trying to think out loud how to answer to that question. Certainly, patient education is important, but I think for patient education, the correct diagnosis and patient identification and treatment is also critically important. Dr. McGuire had mentioned two patient advocacy groups, the UPA and APF, which do a great job in guiding these patients through the journey. But I do think we still have a challenge in diagnosing patients in a timely manner, as showed by the study by Dr. Bunkowski, I believe it was, and it was fairly recent. It was like 5 years ago. The delay in diagnosis is up to 10 years. So that is an unmet need, I think. So I think part of it is that, like I mentioned, is that the wrong test is ordered, right? Instead of PBG, people are thinking porphyria, porphyrins. No, it's PBG if you're thinking of acute hepatic porphyria. And that's an important reason why patients are, and the other thing is getting providers to think about the diagnosis, and then you can figure out what test to order.
I don't know where, when I went to med school, we learned by disease activity. So we went through pulmonary module, we went through the renal module, we went to the GI module, and the porphyrias just don't fit in any of them, because they can show up to the neurologist, they can show up to the hematologist, they can show up to the gastroenterologist, and there's just so many areas they can show up to that it just makes it very difficult for someone to try to focus it. And I think the comment of the question too is just, for the busy clinician, for them to think about it, it's not on the top of the radar because it is a rare disease. So I think it's a great question, but I think you answered that very well. Thank you very much.
I would add, going back to med school, I think also it was also very fascinating, even in med school, right? And then I think it's just as fascinating now. So much we've learned about this disease in the past 10 to 20 years.
That's correct. And we didn't even know about the genes when I went to med school. It was that long ago. So it's been fun. It really has been. Let me throw out another question. This other question is about genetic testing. They've had someone referred with a positive genetic test for AIP. What do you want to do next when they show up in your clinic?
Could you rephrase the question? So they've already had a genetic test?
Correct. So the genetics testing showed up that it was positive for AIP.
Mm-hmm.
What do you want to do when they come into your clinic?
Well, I guess somebody ordered a genetic test and then we don't have an ALA or PBG. Obviously, you're going to start with the history and see, do they have any evidence of an acute attack in the past? The fact is, majority of patients will have one attack or maybe none in their lifetime and never have another attack. Recurrent attacks are seen in the minority of patients. So I guess you got to go back to the history at that point, see if there's something you can pinpoint. And then you're going to have to check in ALA and PBG and see, are they excreting urine? Now, if they are excretors of ALA and PBG, now they are not currently having any symptoms. They may be a whole category of patients, which is called asymptomatic high excretors. And we don't know what to do with this category of patients. It's still in area of study. The asymptomatic high excretors, are they at increased risk for complications? But certainly, now that you have the genetic mutation, you can ask them to avoid medications, which are the most common precipitants, right? Refrain from tobacco and alcohol, which can also precipitate an attack, and take preventive stuff. But I don't know if I would treat that patient just with the presence of a genetic attack, a mutation, sorry.
No, I agree with that. No, that's a great answer. Yeah. But unfortunately, we see it nowadays. Someone goes to a neurologist, they have weakness in a leg, and they do a panel for testing, and one of the tests is for acute hepatic porphyrias.
That is true. And I think there's another related question. Do you ever use a genetic counselor to help with the process and discussion of results from genetic testing? Not sure what the standard is. I can tell you, I personally have a very hard time finding a genetic counselor to see the patient. It's kind of like finding a nutritionist. I can't even find it. Nutritionists, genetic counselors are even difficult to find. So yeah, if you can, then I would probably agree that they should be seen by a genetic counselor.
Yeah, and I would agree, mostly just to make sure all the family members get screened too, especially since 3 of the 4 AHPs are autosomal dominant. I don't see any other questions at this time. You okay? We move to the third learning objective?
Sounds good.
Okay. But please keep the questions coming in, guys. Thank you very much. We appreciate it. So for our third learning objective, we're essentially going to integrate novel therapies for the management of acute hepatic porphyrias. And let's see if I can do this better. This is another polling question for everyone out there. And this essentially in the phase 3 trial of givosiran for patients with acute hepatic porphyria. What was the mean annualized attack rate reduction in the givosiran group versus placebo? So that's essentially talking about people hospitalization, showing up to urgent care, or needing home heme. So your answers are 42%, 53%, 74%, or 91%. Okay, and the answer is actually 74%. Very good. Okay. You guys are on this. Great. You guys read New England Journal. I like that. So now let's move to acute hepatic porphyrias. We'll talk about the management of it. So essentially, after a diagnosis of porphyric exacerbation, the most non-invasive intervention is really to identify any offending medications or behaviors that activate the heme synthesis pathway. Thus, you want to avoid, medications that increase productions of porphyrins to the ALS induction. These would include like phenobarbital, phenytoin, synthetic estrogens, progesterones, and sulfonamides. You also want to avoid patients from fasting, drinking alcohol, and smoking. If there is an infection, you definitely want to look for it and treat it. Patients often experience nausea and non-focal GI discomfort, which should be managed with appropriate antiemetics and pain medications, respectively. Safe antiemetics include ondansetron and promethazine. Safe pain medications really include hydromorphone, meperidine, and morphine. Administration of 10% glucose with a total of 300 to 500 grams per day should be administered. And I usually will do that if a patient comes in. You really want to give them the glucose right away, because our pharmacists, they always have on hand a heman, but it takes a while for them to mix it up. So we just load them with glucose until we get the heman. And then for inpatients, the cornerstone of therapy is really intravenous heman, which has really been available since 1980. It's the only medication that's approved for acute porphyric exacerbations. As mentioned previously, the theory is that increased levels of heme will decrease circulating levels of ALA and PBG through suppression of the ALAS feedback control. Heme is administered 3 to 4 milligrams per kilogram per day. On average, usually takes 2 to 5 days for symptom resolution, sometimes a little bit longer if patients have some more or severe symptoms. The most common side effect of it is really intravenous heman is phlebitis as a result of the anticoagulant effects of heme degrading products. Thus, the risk of phlebitis can be minimized with really using the central access, so like a central vein, even a PICC line can work. And you should administer actually slowly. You can also actually reconstitute the heman with albumin instead of sterile water for further diminish the phlebitis that will occur. It'll actually improve like the stability of the lipophilic heman. The vein really should be washed after saline, with saline actually after an infusion, and heme is generally pretty well tolerated. After diagnosis and resolution of an acute attack, the focus now shifts to really preventing any precipitating factors, and also for patients who suffer frequent attacks that could benefit from routine administration of prophylactic heman, which is usually an infusion 1 to 2 weeks, or the administration of givosiran. Givosiran was FDA approved November 2019 to treat acute hepatic porphyrias. Givosiran is a double-stranded small interfering RNA molecule directed against 5-aminolevulinic acid synthase 1, or ALAS1. Givosiran decreases ALAS messenger RNA1, also decreases ALA levels and PBG levels. Givosiran is given once a month with a dose of 2.5 milligrams per kilogram body weight, subcutaneous injection. The ENVISION trial, which enrolled 94 patients with acute hepatic porphyria, 89 of those patients had AIP. Eligible patients were randomized 1-1 to receive once monthly sub-Q injections of givosiran 2.5 milligrams per kilogram or placebo during the 6-month double-blinded period. Inclusion criteria specified a minimum of 2 porphyric attacks requiring hospitalizations, urgent healthcare visit, or IV administration of heman at home in the 6 months prior to study entry. Heman used during the study was permitted for the treatment of acute porphyric attacks. The median age of patients studied was 37.5 years, ranged 19 to 65, 89% were female. Givosiran and placebo arms were balanced with respect to the historical porphyric attack rate, the heman prophylaxis prior to study entry, use of opioid medications, and patient-reported measures of pain symptoms between attacks. The efficacy in the 6-month double-blind period was measured by the rate of porphyric attack that required hospitalizations, urgent healthcare visit, or IV heman administration at home. AHP patients on givosiran experienced a 74% reduction with a p-value of less than 0.001, and also fewer mean annualized porphyric attacks compared to placebo, as noted in panel on the left side of that slide. On the right side, it essentially shows a 90% reduction, the median annualized porphyric attacks compared to placebo. In this slide, this essentially shows that givosiran also resulted in reduction in urinary ALA and PBGs. These levels drop quickly at 2 weeks and are usually normal by about 1 month. The most common side effects was injection site reactions, which were mild to moderate in severity. Mild to moderate side effects include elevation in serum creatinine, ALT, and AST, but the latter really was not linked to any incidence of idiosyncratic acute liver injury with jaundice. It is recommended to check LFTs and renal function Q-month for the first 6 months of therapy. Less common but more severe side effects include severe injection reactions and anaphylaxis. Other side effects include rash, nausea, and elevated homocysteine levels. And what about liver transplantation? The alternative to suppressing ALAS1 activation is correcting the gene defect with PPG deaminase throughout the liver. Liver transplantation really is an effective treatment option with almost universal resolution of symptoms and normalization of biomarkers with the exception of people with chronic neurologic manifestations, such as psychiatric disease and axonal degeneration, which really has not been shown to improve completely with liver transplantation. At UAB, we have not evaluated a patient for liver transplant. I'm sorry, we have evaluated patients with liver transplant. We really have not transplanted anyone with AHP. Manish, any of you guys transplant anyone with AHP?
No, not at Jefferson. No, we have not transplanted anybody with AHP, although Mount Sinai has done one, and I think there was another one in the US, if I'm not wrong. So very rare indication, but definitely is curative.
I think the cases we've had, it's someone that essentially has gotten IV Heman, and essentially they've lost all their access sites, and that was a consideration. Someone else who had bad nausea and vomiting and couldn't eat. Those are the only ones I remember offhand that we've evaluated. But really, we're hopeful with current treatments and even future treatments that transplant will even be less and less of an issue regarding this.
Right. I think we should just take a couple of more questions. I think there's some very interesting questions coming in. I think first question probably is, it says, how does givosiran impact the pain associated with acute hepatic porphyria? Do you want to take a stab at it, or I could go either way?
No, I'll take it. So I guess we know ALA causes this condition. Elevated ALA levels, it causes nerve damage, and it's amazing. We can talk about this too. How many patients you have that you're treated with givosiran, you see their ALA, PVG all normalize, but they still have abdominal pain. And I think it takes a while because I think there's still permanent damage that has occurred in some of them. Some of them, you've lived your entire life with this abdominal pain. And I think anytime you get some pain too, you start thinking, oh, this has to be a porphyric attack. Sort of like what you said before, you got to think of other things too. And sometimes think outside of the box or outside the abdomen. So I think that with the nerve damage, even though it normalizes everything, some of that damage is not 100% reversible. Sort of goes with the liver transplant data too.
And I think you hit it right on the head. And I was talking to, there was a European meeting I just came back from like 3-4 weeks ago. Kind of the same experience. The pain does not get better in a month. The ALA PBG levels normalize in a month, but it usually takes, a little bit longer, 4 to 6 months. And even though they may have pain, it's not as severe. I just saw a patient today who has been on givosiran. Her pain is more vague feeling of unwell and some more neuropathic pain at this point. She's not having acute attacks. They're just sending her into the hospital. And I'm quoting her from today. It's like, I'm 70% better. So, and every patient is different. It depends how long they've had it, and everybody's pain threshold is different. So it does, and there's data that shows from the study that they have decreased narcotic requirement and improved pain levels. So, yeah. The next one is, I assume that once monthly subcutaneous administration of givosiran helps with adherence. Does the patient self-inject, or is a clinic visit needed each month?
Yeah, I don't know how many you have. I probably have 10 patients on treatment, and it varies. It depends on where they live. I live in Alabama, and people come far away. If they live close, we have them come to clinic. They get their sub-Q injection, they get their labs, and they go. Some people, though, their insurance won't allow that to happen here. And so we end up using their mail order pharmacy that essentially will ship the drug to their house. And then a home healthcare nurse will come and give them their injection once a month. And I still like getting labs the first couple months just to make sure that the LFTs are fine, the creatinine's fine, and homocysteine levels are okay. So my preference is for them to come here, but I understand they can. And if a home health care nurse can deliver it, make it happen.
So in the Envision study that Dr. McGuire presented data from, there was one patient who had an anaphylactic reaction, right? And that's why the FDA label calls for that the drug should be administered in a monitored setting. That's what I believe that's what the label says. And my practice has been to administer at least the first 3 injections in a monitored setting. And then you transition to a home health, and I think Alnylam has, they have partnered with Panther and one other pharmacy to do that for a nurse to go out and give the injection at home. Now, do I do that for all patients? No, but I try to do it. And it's certainly not feasible in some, because they're worried, and so they come in. But the goal is to transition to a home after 3 months. The next question I'll probably take is, are hematologists needed to administer hemin? Should they be involved in other aspects of management? Well, I think, as you will see in the later half of this presentation, this is a disease that involves multiple organ systems, and the goal of the management is have a multidisciplinary management. And I personally, there's few patients that I have who get hemin through my office. There are other patients who get hemin through hematologist's office. So whatever it takes to take care of the patient, I think that's what's needed. And it's a multidisciplinary care model that really needs to be in place.
No, I agree. No, you answered that very well.
Do you want to take the next one about transplant? It says, if a patient with AIP are not in hepatic failure, how do you convince insurance companies to pay for the transplant?
Yeah, no, it is a great question. And I think that's why there's so few cases that have been done. No, but you're right. It will be an appeal letter, and we've done appeal letters for other transplants. But you really have to lay out your cause. You have to lay out that they've tried Heman, they've tried givosiran, they've tried everything out there. You have to lay out if it's a rich issue with IV access, as I said, because they can thrombose IV access to do it that way. Is it an issue that they show up on a ventilator and that's their first time presenting and you don't want them to get another attack? I mean, those are really the major reasons why you would do it. So, but you're right, though. It would take an appeal letter. The insurance company would have to approve it. And that's how you'd have to make it happen.
All right. Let's take one more before we move on. This one, it says, because I think it's what we have covered earlier. It says, are the diagnostic urine tests for AHP relatively easy and inexpensive? And the second part is, should they be done empirically for anyone with severe abdominal pain? They're easy if you know which one to order, right? So most of the times it's the wrong test that's ordered, right? I cannot speak on how much they cost and how much the insurance gets billed on. I don't know the answer to that question, but I've not had pushback saying that they were really expensive. I've never heard that one. And maybe Dr. McGuire can let us know if he's heard that. But to answer the question, should they be done empirically for anyone? I think if you have severe recurrent abdominal pain where the cause is unknown, I would recommend that they be tested for ALA and PBG, or PBG at the very least.
No, I would agree with that. But like everything else, you have your differential. And I must admit, for abdominal pain, it's not in the top list of causes. And it should be, because there's other life-threatening ones that need to be ruled out first. But I think once you start ruling out first and you still have abdominal pain, then I think acute hepatic porphyria has to be down after that.
Right. And let's move on. I think we can come back to the rest of the questions once we keep moving. So this is our last learning objective, which is to implement long-term strategies to manage and minimize disease burden in patients with acute hepatic porphyria. So we're going to go on to another audience response question. The question is, how often should patients with AHP over the age of 50 be screened with ultrasound with hepatocellular carcinoma? Annually, biannually, once every 2 years, quarterly, and I'm not sure. Let's go for it, guys. So AHP over the age of 50. So the correct answer is biannually. So over the age of 50, you should be screened every 6 months for HCC. So these are the long-term consequences of acute hepatic porphyria, which I will attempt to cover in the next few slides, chiefly talking about HCC, hypertension, renal failure, and psychological trauma. Liver is thought to be the major site of PBG deaminase activity. And a small percentage of patients with AIP will have non-specific elevations in the liver enzymes, especially during an acute attack. Looking at the risk of hepatocellular carcinoma, there was a Norwegian cohort of 251 patients, and they looked at the annual incidence of HCC in this cohort, which was at 0.35%, and comparing it to the general population, the risk of HCC was 0.003%. So in Norway, in their cohort, they showed there was 100 times increased risk of hepatocellular carcinoma. A similar French cohort, which followed patients over 7 years, showed a 36 times higher risk of hepatocellular carcinoma in gene carriers as compared to controls. US data was published a few years ago in hepatology, and in the consortium database, they found 5 cases of HCC in a group of 351 patients, conferring a 1.5% risk of hepatocellular carcinoma. It is thought that the 5-ALA dimerizes at supraphysiological concentrations, and which can induce pro-carcinogenic precursors. So the recommendation generally within the field is that patients with AHP over the age of 50 should get an ultrasound every 6 months with or without an AFP. And obviously there is no data about the utility of AFP, but most of us will throw in an AFP at that point. Hypertension is another chronic disease manifestation. 60 to 70% of patients with AHP have chronic sustained hypertension. And this may be related to autonomic dysfunction. And I was preparing for this talk. In 1954, they described neurogenic hypertension in a patient with porphyria from Chicago. And it was transient with tachycardia. It was an interesting article, but so it's something to be aware of, and then they need to be treated. Chronic kidney disease, up to 64% of patients with symptomatic AHP have CKD. Now, this is independent of hypertension. The estimated decline in renal function is about by 1 ml per minute per year annually. And again, it's the ALA and PBG, the precursors which accumulate, which are thought to be nephrotoxic. There is recent data about how PEP-T2 polymorphism may explain why some people are at higher risk of having elevated creatinine as others. So there's a genetic polymorphism that predisposes people to have kidney disease in the setting of AIP. In the EXPLORE, which is the natural history study of AHP patients with recurrent attacks, it was a precursor study to the ENVISION study. Renal disorders were reported in about 10% of the patients. However, when we looked at the medical history, 70% had abnormal EGFR. So kind of similar, 60 to 70% risk of chronic kidney disease. And 30% of these patients met criteria for chronic kidney disease, stage 3A, 3B, or 4. So I hope you keep this in mind. 22% of patients with acute hepatic porphyria, as with other chronic diseases, report moderate or severe anxiety. My guess is this is probably higher, but that's the reported. 15% have depression, and this population does have a much higher rate of suicidal ideations and suicide rate in general. An important resource that I would point you guys in, and this I'll be remiss, there are several drug databases maintained by several organizations, the APF, the European Organization, Drug Porphyria, as well as there's an app, porphyriadrugs.com, that I encourage all my patients to download, because anytime I tell them you're looking for a new medication, you need to check the drug database and see if they're porphyrogenic. Another thing that I would probably mention from my clinical practice, I do ask them to get an alert bracelet. It makes sense that they get an alert bracelet. Finally, the manifestations, the disease presentations and patient presentations affect more than one organ system. And what we really need to focus on is a multidisciplinary approach, which obviously involves partnership between hematology and gastroenterology. As mentioned, kidney disease, for nephrology, they need to be involved, psychiatry, nutritionists, and pharmacists and our physician extenders and providers who can be a resource in managing these patients along with the primary care providers. So to summarize, we have to increase awareness of AHP in our practice to avoid long-term delay in diagnosis and treatment. And we have to implement diagnostic testing in appropriate patients, and the right diagnostic testing, might I add. And you have to assemble a multidisciplinary team to provide comprehensive acute and long-term care of patients, and certainly keep abreast of new developments as they become available. So we can take some more questions at this point. Dr. McGuire, comments?
Yeah, Manish, no, that's very good. Your multidisciplinary slide, the only other thing I would add is my secretary. I don't know about you, but there are certain patients that are going to get hospitalized, and they're going to have attacks, and every time, because their levels are really, really high, and they're very predictable, right? And so I tell my secretary, I say, hey, if this person calls or that person calls and they say they're having a porphyric attack, you just got to believe them, right? And usually when they come in, I will always check ALA, PBGs. When they come in, they're always elevated, and so these people, they know what their attack is most of the time. But you're right, though, you always got to think of something else. But if it's pretty typical, I will actually directly admit them to our hospital and put them on our liver service, and we'll manage them that way. So.
Right, and to that end, I usually give a lecture to the fellows at least once a year, especially the new fellows. We do have an epic order set for porphyria, and at least they get attuned to, if it's a known patient, they come in, just put them on Heme. Don't wait till tomorrow. Don't wait for the PBG. So absolutely. So yeah. I can take this next question. It says, how do you balance the efficacy of givosiran with the risk of hepatic and kidney adverse events? Let me start with the hepatic adverse events, right? Certainly, it is a very effective drug, as we've discussed, and it does change the life of these patients. It does carry a risk of elevated liver enzymes, and for that reason, you monitor the liver enzymes at least in the first 3 months. And then I go on to every 3 months, I want them to have blood work done, I monitor their kidney function. So it's not without risk. I'm not saying, there's nothing 100%, but if your liver enzymes go up more than 5 times, then I consider dose reduction or stopping completely. Kidney adverse events, again, there's a big nuance, because I just showed you data how patients have kidney disease even in the absence of givosiran. So you have to monitor them closely. A lot of times they're dehydrated, and I tell them drink water in the morning before you get your CMP drawn. And believe it or not, it does come down by 50%, 30%, and but that does not mean that you don't monitor it, and it's a risk-benefit analysis. So I hope that answers your question. You want to go for another one, Brendan? Anyone?
I think that answered pretty good. Yeah, no, I'll go with another one here. Okay. Sorry. I don't know. There we go.
While you do that, let me answer this one. Do you recommend pain management specialists for treating intractable AHP pain? The short answer is yes. If they have intractable pain, which is occurring, and it depends on what state you're practicing. If you have a New Jersey license, you cannot prescribe more than 7 days of pain meds without seeing a pain medication specialist. So the answer is yes. Short answer is yes. What is the usual interval between attacks? Very variable. If a patient has recurrent attacks, I do try to get them on givosiran sooner rather than later. And would it be safe for patients to use opioids if attacks were spaced apart by several weeks? Yes, and I would refer you to the database. Go ahead. Sorry, Brad.
No, but I think you're right. I mean, that's where the multidisciplinary. Do you have palliative care at your center? Do they get involved with your patients?
We have palliative care, but I don't think I've involved them for AHP patients,
Yeah, I have. I actually recommend it. I just think they have a different mindset than we do. They are just more calmer. They are more, I think, understanding than I am. And but they've dealt with it at all spectrums, from patients at end stage of life to patients with chronic disease. So I don't know about you. I don't have a chronic disease. And I think it would be terrible for anyone to have a chronic disease. All these patients do, and they just never know when it's going to jump up and start attacking them. And it truly is a different world than I live in. And to live in fear knowing this pain is going to come up. So I guess I try to push them to talking to palliative care. And it's really just for pain management and dealing with stress and chronic disease that you mentioned earlier.
No, that's a good suggestion. I mean, it's part of that, whatever it takes to take care of the patient. Absolutely.
Yeah. I have another question. Is there awareness of porphyria among different professions you listed? Do you know about all the different symptoms that can occur? I think really, though, your list of the multidisciplinary approach, I mean, they will show up to different ends. So I think, it can show up anywhere, and I don't know about what you've had in terms of referrals, but I can guarantee I've gotten it from, have you ever gotten it from a nephrologist? I've gotten a diagnosis once from a nephrologist. So I thought, boy, that's a strong, astute physician to do that one.
No, I have not. I had it from neurologists for sure, but not a nephrologist. I had a VP patient from dermatology, but not nephrology. No.
Yeah, and I actually had an internist from rural Alabama here refer someone. That was pretty cool too. That he made the diagnosis and he did the right testing and everything like that. So you love when things like that happen.
So I think this one here, do patients often run into issues if they have to seek care in the ER? It seems like there would be a chance of them being labeled drug seeking or malingering for people not familiar with the condition. So yes, people do run into issues when they go to the ER, the wait times, and sometimes ER is unavoidable. Most days of the year, if I were to call a patient for an acute bed in my hospital, they're going to be waiting for like 2 days for a bed, unless they go to the ER. And we don't even have them wait in our clinic because we don't know what time they get called in, 6 p.m. or 9 p.m. for a bed from the clinic. So it's unavoidable at times. And, the second part, that is true. And I think that is why it's important to come to a definitive diagnosis, increasing awareness. And once they have a diagnosis, and if you have an order set in your EMR, people are likely to use it. They're going to, says order set says give Heman, and you're going to use it. So, then they're going to require less pain meds because you're treated early on. And hopefully, that's not the solution, but at least that's part of the solution to the problem. Next.
How about another question? Patients with acute hepatic porphyrias, you want to start a new medication, there's no data in the databases. What do you do?
So obviously it's a risk-benefit analysis, right? Again, at that point, if there is no data, what's the right word? Nothing in the database. I ask them a simple question: why do you need it? How much does it bother you, right? And if you don't need it, if it's a mild, let's say mild pain, 1 out of 10, and a heating pad would do it, that's fine, the second thing is you can monitor them, right? If they are on givosiran, I have a patient who has leukopenia, and they wanted to try her on a new medication, but she's lived with leukopenia for like 50 years. So she decided not to do it. I said, hey, and this was pre-givosiran, and when she was on Givo, and I said, go ahead, try it. But at that point, she's like, I don't want it. I'm okay. I just don't want to take it. That's fine. So I think it's a risk benefit and a discussion that you have, and what your ability to manage that patient at that point is.
Yeah, no, I agree with that. And I had someone too, and I don't know what's right or wrong. I said, I don't know whether this drug is safe or not. Let's check baseline PBGs, have you go out, come back 2 weeks later or a week later and recheck the PBG or ALAs, and see if they increase, and that's all I know to try to. And I've tried that, whether there's science behind, there's nothing, but if it goes up, you can say, hey, you shouldn't do this. If it stays baseline, you can say, okay, it's safe. But I think there's just so many new drugs coming aboard for various different conditions. It's hard for any of these databases, Norwegian or the American Porphyria Foundation, really keep up on it.
Right.
Yeah.
So I think another question is, are there any issues with prior authorization or insurance coverage for givosiran? Huge. That's it. Short answer is huge. As with anything, it's a very expensive drug, right? And it takes few months, unless until they have Medicare, for it to get approved. And I think the other issue is, at open enrollment time every year, patients get dropped all the time. So that is an issue. Now, this is not just an issue in our country, but also other parts of the world. There's a growing discussion in the community, in the field, about how long do you be on givosiran? Do you really need to be on a $500,000 drug for the rest of your life? Is 2 years good enough? Can you space it out? Again, that's beyond the scope of today, but those are all questions that are valid questions. So,
yeah. Another question here: when is carbo loading appropriate as a treatment strategy? I mean, there's plus minuses, right? When you start someone on it, unfortunately, people gain a lot of weight on it, and that's their biggest complaint. But I think if they start people have a prodrome, sometimes they feel like they're starting to get some abdominal pain, and that's usually the start of it. And I usually tell them to encourage then to start doing it. And then, as we said, when they come in the hospital, you load them up pretty quickly.
Right. And I think there's one last question that has not been answered. It says, you said most people with AHP, which is rare to begin with and have no symptoms, is there any danger in living with AHP if it isn't causing patient symptoms? I mean, most patients with AHP are not being treated because they don't have symptoms. The indication for givosiran is patients who have recurrent attacks, right? And again, like I mentioned in my comment just a few minutes ago, people are saying, okay, well, how long do you need to be on it? So just because you have a genetic mutation doesn't mean you have a disease. Just because you have ALA PBG doesn't mean you need to be treated. You could be an asymptomatic high excreter. if you're having symptoms, if you have elevated ALA and PBG, you should be treated, especially if you're having recurrent symptoms.
Yeah.
Brendan?
I agree with that. And would you ever treat any? So I have people come saying, I have a sibling that has it, and they've gotten I've had this recently, they've gotten so much better on it. I know I have the gene defect, can I get treated? And I go, well, what's your symptom? Well, they name a couple different organ systems. They tell me I have headaches, I have leg pain, I have abdominal pain, and you check ALA and PBG and they're stone cold normal. And I won't treat anyone unless I have elevated ALA or PBG.
And that is true. I mean, I kind of echo your thoughts. And at that point, I say it is really beyond me because I don't have an answer, we don't even have an answer for asymptomatic high excretors. Forget anybody who has normal PBG, right? So it probably is beneficial to lower the PBG, but again, it's probably, we don't know how long, and because it's a chronic disease, it has other organ system involvements. So
I don't know how you started when it first came out. I said, I'm going to all the patients that have been really hospitalized in the last year. I'm going to treat them first. And those are the first one I lined right up, and I got them on treatment, and I just wanted to see how they did with it, and then after that, then I think I moved to the next group of patients that said they had pain. They weren't that severe. They weren't being hospitalized for it, but they definitely had elevated urinary ALA and PBGs. So I went after them next. And it's like when you talk to them, like any other patient, you go, okay, I know this medication will lower your ALA PBGs. I know you haven't been hospitalized. Here's what it does. Are you interested in trying it? And then go from there. And, it's very interesting. Some patients have just had the disease for so long, they're not sure what all their symptoms really are. And I've just had some people that say, once they started, they go, boy, I feel so much better now. And what do you mean? Well, I wake up every day, I'm more excited. I just have more energy, and it's kind of crazy in one way, but a lot of them just have had it for so long, and they never had an acute attack where they're hospitalized for it, but they always had elevated levels, so it's interesting to see. And it's been fun treating people with the medications.
I think there's another question about gene therapy. So there's a Spanish group who has vectors, and then they're looking at gene therapies, and they had a presentation at this international meeting recently. And basically the bottom line is they're looking for funders, investors to invest so they could go on with the phase 3 study, if I'm not wrong. So that's where gene therapy is. Somebody needs to either buy them out or fund them for the next phase of study. So you want to go
get there. It'll get there, right?
I'm sorry. It will get there. I mean, we were at the presentation, and then after that we came out. I was like, Alnylam was there. Why aren't they buying these guys out? What are they doing? I was like, I don't know, but I guess So anyhow, that is what it was. We were kind of surprised by his comment. Everybody was like, "Wow, man." Okay.
Yeah, but yeah, we'll get there. We will, and I think we'll get there sooner than later. It's actually been fun to see.
Oh, the field has advanced so much, especially with the givosiran. Absolutely, there's no question.
Yeah, when you think about it, we had Heme we still have it, we still use it, but we had it for 40 years, and there was really nothing else in the field.
Right.
So that is cool. And I guess we're running down on time. Thoughts to the crowd out here. What should be their takeaways? What do you want them to take away with and remember from the talks today?
I don't think they can type in their thoughts, Brendan. I don't think they can speak on the Zoom platform or whatever we're using.
Okay. But I mean.
Oh, you wanted me to give, I'm so sorry.
Yeah, as a physician, I guess, treating these
oh,
patients.
I thought you were asking for more questions. So
No, no,
my
no.
bad. No. Okay.
I
Well, I
think
think my thoughts to the group is I guess, thinking about it in the right setting, and then knowing how to order the right test. So I think establishing a diagnosis early on, and then treating these patients, which I think most people are familiar with, or they can become familiar with the help of the pharmacists or resources that they have available in the hospital, utilizing I think a team-based approach to managing these patients, and kind of going from there. I think that those were the top three things I would say.
and I would throw out, and I agree with all your comments, but I think managing these patients have made me a better physician taking care of other patients with other diseases. And I guess I say that just because, it is a chronic disease, you're really relying on the patient to help you with the symptoms. It's not like you can order ALA and PBG and find them elevated, but you really got to listen to them and listen to their needs and really spend time, because, most of them were really desperate before they had a diagnosis. And how many times have you talked to someone and they give you a diagnosis and they just are so relieved? They say, I have something now and I'm not crazy,
Right.
And so, and
Absolutely.
yeah. So I guess it's, we go into this business trying to help people, but I think people help us and patients help us just as much as anybody else. So it's really very interesting in how things come back around. But I think it's been fun. But okay, I'm rambling now.
No, I think you gave good insight, and a 10,000 feet view of I agree. I think it can be challenging and daunting to start off with, but I think the patients that you can help are very appreciative and makes it worthwhile.
It really does. No, I agree with you. Thank you. We're just about out of time, and I really applaud the audience for all their excellent questions and really to keep this discussion going. So I really appreciated it, and I really want to thank Dr. Thapar for his great discussion, and thank you really for joining us today. This was, I thought, very interactive. I thought worked out very well.
Thank you, Dr. McGuire. It's an honor, and I would say I really enjoyed it, and hope the audience enjoyed it too. Thank you.
You're welcome. Thank you. And this is essentially our final slide. So please continue to follow us on CME Outfitters on behalf of Dr. Manish Thapar and CME Outfitters, who will continue to provide education, tools, and practical resources to help you and to help manage patients with acute hepatic porphyrias. We hope you found this webinar helpful, and we look forward to interacting again on future webinars. To receive CME or CE credit for today's program, please complete the post-test and evaluation. You will be able to download and print your certificate immediately upon completion. Thank you very much for everybody. Please be safe and have a good night. Thank you again. Bye-bye.